So which one's here?
I'm Rob Hernandez, and what I've done to present to you is it's a postmaster's predoctoral paper that I've written. It's draft. It's in draft form, and I sort of assembled it last night as I was thinking about this. But what has caught my attention for quite some time is this slide from APS's own training.
Mr. Hernandez, let me interrupt. You do have a copy of this paper at your place. Sorry about that.
That's from the follow-up.
And under their own training, it says, a history of repeated emergency room or hospital admissions is an indicator of physical abuse. The question that raises to me is that we know that individuals with IDD, 40% of them are diagnosed with 4 chronic conditions or more. And let me read to you the chairman's own words. People with IDD are far more likely than their typical developing peers to experience health disparities, disproportionately higher rates of chronic disease, and have access to preventative primary care and health promotion resources. And because there are excessive wait times in this country, 4 weeks or more, for this population, they can't wait 4 weeks to see the PCP. And so the only other option that they have is if they don't have option to, if urgent care isn't available, but many times our urgent care facility can't handle the types of treatment that they need that an emergency room can. And so you're going to see more IDD individuals with chronic conditions in emergency rooms. And particularly, Maureen and I have heard of several cases where the physicians have said, if this happens, here's the standing order. Here's our standing protocol. You take little Susie or little Phil to the emergency room because my office is not open on the weekends. And so you have a standing order. And so if they're Kaiser, which has excellent electronic health records, that will all be there. And so the attending physician can say, oh, this is why you brought little Susie and Sally in, because of their chronic condition. That can be treated, my clinic's not open, or what you will see is that you might have a surgeon who will say, well, wait a minute, we can do this procedure in the emergency room as opposed to keeping the individual hospitalized for 3 months or for 3 days, waiting for a slot in the operating room. So they're trying to lean it down, and for whatever reason that might be, it's a surgical procedure, but it saves money and it saves time. However, but according to this, that would be a history of repeated emergency room or hospital admissions. So what I'm trying to explain to you is that people with intellectual developmental disabilities are going to have these chronic conditions. They are born with them, they are diagnosed with them, and you will continue to see them in emergency rooms, especially when physicians order them. So keep that in mind as you're looking at rules, but there are lots of findings that say, as you look at this, and I won't read this word for word, but I wanted to have this available for you for reference so that you can see. And two of the references that I printed out were done by the chairman, along with another colleague. But that's why it was important for you to understand, to bring that forward, so you know that people that work with this population, certainly the chairman understands it because this is what he does. Certainly Maureen understands it because this is what she lives. I mean, families and people who do this, they live this every day with people with intellectual developmental disabilities. So what I'm asking the board to really consider is that take a look at this very closely, and weigh that against the rules and the potential rules that you might see coming forward, because you have to understand that records are there and doctors are mandatory reporters. If they see something amiss, it's their duty to report it. They're not going to just sit there and say, oh, we didn't see something. But when you see chronic conditions come back into the emergency room time and time and time again that are part of a doctor's standards orders, and we've seen cases where APS has completely ignored a doctor's orders and said, well, we're going to substantiate everybody because that's what we do. The problem is that I talked to a physician today who's a PCP for an IDD individual, said, Rob, I can't disclose anything, but I've had APS come forward to me and ask me to change my notes. I said, well, I can't do that. I'm a medical doctor. I'm not an investigator. I've reported to you what I've seen and what I've ordered and what I've advised. And so you need to understand that there's a whole set of unintended consequences that might happen as a result of someone sitting there, and I forget who asked the question about, is this maybe Mr. Davidson, you asked, is this consistent county by county by county? We're not seeing that. I mean, what Maureen is hearing and what I'm hearing is that one county might do more guardianships, or they might do more substantiations than another. In other words, even though this is a state-operated, the state has oversight, you have 64 different counties with 64 different ways and interpretations of doing things. But my point being is that I did all this research just so that you would know that IDD individuals are going to have repeat emergency room visits.
And the last thing we want to do is have parents not take their individual, or anyone take anyone to emergency room because they're afraid of being flagged for APS when in fact they need care. See what I mean? I don't want that to be a barrier to care, the fear.
And in addition to that, because when you jump to a preponderance of evidence, which is the next thing, just because someone has gone to an emergency room is not a preponderance of evidence. That's medical care. And had the family or families not do that, then they would be guilty of mistreatment for not taking the birth flag. You sort of see the incongruence here. And so that's what I wanted to point out. That's why I spent some time doing this research, so you would understand that this part about emergency rooms or repeated hospital admissions probably needs to have a second looker taken out. So just wanted to bring that to your attention. That's why I spent some time doing this. So thank you very much. And do you have any questions?
Thank you, Mr. Hernandez. Questions? Ms. Watkins?
It would be my. I hear what you're saying for
Yes.
sure, but isn't this something taken in full? I mean, obviously, someone's bleeding. That's not going to be the department's not like. I mean, this is a whole host of things that if multiple things were happening. So I understand your point about certainly someone should be taken to the hospital anytime emergency care or care is needed and a physician is not available. That should not be in itself a reason for substantiation, but taken all together, you could start to see patterns. Do you understand?
Mr. Hernandez?
Thank you, Mr. Chairman. Except the reason I bring this forward is because the focus was emergency visits and repeat hospital admissions. And we know of a couple of cases where APS jumped in and has guardianship, and we've seen repeat emergency room visits. We've seen the care get worse, is what we've seen. So that's why. So they started off by saying, a family member, you took little Susie to the emergency room, so therefore we have determined that you are a perpetrator and guilty of neglect. So that's why I focused on this. So yes, all of the other things, but this is a critical piece. So when they focus on this and jump in to do the things that they do, that's the part that I'm separating out, because yes, I would agree, but that's not what's happening with emergency visits or hospital admissions. That's why I did all the data and all the research to show that that's not what's happening.
Any further questions for Mr. Hernandez?